the different kind of D-SNPs and why they can impact services. Welcome to the CarePayments Pod. I'm Fady SaHhar, president of Extra Globex. This is the second of two podcasts to cover the important elements of integrated care associated with LTSS participants and D-SNPs. With me is Mandy SaHhar, the co-author of the VBP blog and DEHQ.
Hey everybody, excited to be here, excited to continue our conversation on D-SNPs. So last time we talked about that. We talked about D-SNPs in general. Who are they? Who it impacts? Why it matters? And today we want to cover the importance of the coordination of care and how it works and the different types of D-SNPs that are available. So Fady, let's start there.
Thanks, Mandy. So, coordination of care is such a pivotal hub in how consumers receive their services. And so, when you think about the different levels of coordination of care that occur within a D-SNP program, we are the ones that now determine how we dial up that level of coordination of care. So, at a minimum, the minimum we expect is for one entity to be able to assess the needs across the spectrum of services that the consumer needs, but also that coordination of care to be looking at the overall health and well being of consumers. Coordinating care is more than just uh, looking at the records, it's monitoring the transitions from hospital to the community or from skilled nursing facility to a community, assisting and maintaining the level of Medicaid services, especially in this time when revalidation is such a big issue and eligibility is such a major concern. So we also need to make sure that we're exchanging data. So the more nodes that we have in the data chain, the more difficult the coordination gets to be.
Yeah, it makes sense. And, it just doesn't stop there, right? It overlaps with Medicaid, and we see such a big impact on the social determinants of health. So, SDOH, common acronym out there, right? Conditions in the environment where people are born, live, learn, work, play, worship, age, all those kind of demographics. And they affect a wide range of health, functioning, and quality of life and outcomes and risks. And that's straight from HHS, right? So when we think about the D-SNP responsibility to coordinate with SDOH and how that overlap is happening, they need to learn about each individual, their situation, address those social determinants of health, and think about the benefits and supplemental benefits that are needed by using referrals and other sources and through collaborations and partnerships to really put the person first, right? As we think about those things.
Absolutely. And this really highlights why the wherever we have a higher level of integration, that coordination of care becomes smoother.
Right.
We have some individuals, very few individuals, that are engaged in coordinating that consumer's needs. I'll tell you, as an advocate, we also worry when there's only one individual or one organization looking at the whole person
Of
because
course.
that they may be looking at other priorities. So while we're going to walk through the different categories of these SNPs, we want to keep in mind that this is about keeping the consumer healthy, not just the health of the organization that's delivering the services. So let me start with one of the categories of D-SNPs that it considered to be the holy grail, which would be the fully integrated D-SNP. And a fully integrated D-SNP is exactly what it sounds like, where all of the activities, all of the supports that an individual needs, whether it be in their medical needs or in their community needs or their non-medical services, are being delivered through the same organization. And that organization is usually a managed care organization. That includes the vast majority of the services that they need, so that the individual needs. And so you start to consider whether especially individuals who may have uh, different levels of illnesses that they may be experiencing. A person with diabetes may have very different needs, both from a medical standpoint as well as in the services they receive in their home. So think about the simplification that a fully integrated uh, uh, D-SNP can provide, because now you have a single person or department that manages the physical health needs as well as, in many cases, the behavior health needs and the LTSS services for both. And we're not worried in this setting about who pays first, because
No.
Medicaid is the payer of last resort. So
Right.
you find that if a Medicaid organization is trying to determine what it pays for, it's trying to push up some of the spending upstream. A fully integrated D-SNP makes that a lot easier and simplifies the process by which people can get there.
So if we think about it as a progression, right? So the fully integrated DSNP would be 100 on a scale of 1 to 100. But there's obviously other levels in that progression. So the way that I understand it, the highly integrated DSNP would be somewhere around 75 or 80 on that scale. And
Yeah.
that, is a SNP or a matching MMCO that has a contract with the state to provide most of those medical services, but not all of them. So they're still
Mhm.
getting a lot of what they need, and that D-SNPs provide that coverage to get most of the coverage they need. So this highly integrated or HIDE SNP can carve out behavioral health, long-term services, supports, all the things that we'd anticipate that they would need, and it can come from those two different entities, the MMCO and the D-SNP, as long as they're affiliated. Am I understanding that
Well,
correctly?
yeah, and so the key element for a highly integrated D-SNP is a high D-SNP is one where you have exclusive relationships between the physical health MCO and the LTSS providers, for example, the Medicaid services providers, so that you're acting as if this is a single organization, but you have multiple levels of coordination of care that has to happen when you're dealing with a highly integrated DSNP. So, a little bit more complicated for the consumer, but start to get that balancing factor of where do we get all the input that we need to make sure that the consumer is receiving all the care they need rather than a single perspective.
Yeah, that
Because
that completely makes sense.
yeah, and so there's a third category of these SNPs, and these are obviously, as you look at your continuum, you mentioned the 100 and the 70 to 80%. Now we get down to the 30 or 40%, where the primary reason for the DSNP is to do a coordination. They're coordinating the services for the consumers they serve. And in those situations, you don't have an exclusive relationship between the DSNP provider and the LTSS provider. You have two organizations that are expected to play well together, to coordinate the activities. And we see that this provides a lot more consumer choice. It provides a lot more latitude for where and who is involved in delivering the care. But what it doesn't provide is that simplification, because somebody there is acting as the coordinating body, and they're channeling the services. You find that in a coordination only DSNP, the networks of providers can be very different, right? So their responsibility is to make sure they have sufficient, adequate networks. They don't have to have maximum choice. It's not all willing providers, and
Right.
so as you see this integration start to, the continuum of integration, you start to have to evaluate the pitfalls that are associated with some of these different levels of coordination of care.
Yeah, so we went through the three different levels, and as advocates, it's important for us to consider, what that communication with participants really looks like, right? Putting participants first, and how does all these options are, fine. They're some of them are better than others, of course. So, what are your thoughts on how that's communicated to participants?
Well, uh, when you're creating communications for participants, you have to be clear about what you're expecting from the consumer in this continuum of care, because they're used to something different. Today we have a limited number of highly integrated and fully integrated D-SNPs. Yet, as we look down the road, we see some real efficiencies of scale, as well as some opportunities for improved services for consumers. And so, well, it's important that as advocates, but also as folks who are coaching through the choices that states and MCOs and providers make, to understand that the expectations are different. The more integrated the program is, the more likely it is to come with restrictions on choice. The less integrated it is, the more choices you have. So as an advocate, you can see the value of highly integrated D-SNPs, but you can also see the cost that comes with them.
Yeah, of course. Of course. Well, we're out of time today. I really enjoyed talking 2 podcasts about D-SNPs with you. And for our audience, if you missed the first one, please go back, go listen to it. It'll help set a framework for today. But thank you so much for being here today, and let's chatting about it. And as always,
Onward.
onward. Check out Paying for Outcomes, the value-based revolution. The link is in the description here. You can also get it at vbpblog.com. The CarePayments Pod is brought to you by Extra Globex. Extra Globex is a strategic consulting firm that works with companies that are at an inflection point. We work with organizations to help manage that change and meet your goals. What is your challenge? Let us help take you onward. Link in the bio for a free consultation. Visit us at extraglobex.com.